Okay, shall we start, Rajesh?
Yes, please.
Okay, great. Okay, hello everyone, and welcome to the ICTS Colloquium in its new present avatar. So I think we all know why we are joining online, and our speaker today will perhaps enlighten us more about the current situation. Before I go ahead and introduce the speaker, I wanted to make some statements regarding house rules. If you have any questions, you can raise your hand. To do so, if you click the participants tab at the bottom, a small window will open that says with an option to raise your hand in that small window. So once again, if you click participants at the bottom, you'll have a window that says raise hand. I'll try to pay attention to anyone with a raised hand and interrupt the speaker. And then the person who raised their hands can unmute their microphone and ask the question. In the meanwhile, I see everyone else with muted microphones, and I think we'll try to maintain that. So our speaker for today is Professor Rajesh Sundaresan. Professor Rajesh Sundaresan is from the Indian Institute of Science. He's currently associated with the Department of Electrical Communication Engineering, the Robert Bosch Center for Cyber Physical Systems, and the Center for Networked Intelligence at the Indian Institute of Science. He received his PhD in electrical engineering from Princeton University in 1999, built communication modems at Qualcomm till 2005, and has been at the Indian Institute of Science since. He's had some brief visitations to Qualcomm, University of Illinois Urbana-Champaign, and the Toulouse Mathematical Institute. His research interests are in cyber physical systems, cyber social systems, and aspects of information exchange in such systems. The title of his talk today is Agent-Based Simulators for the Study of COVID-19, and I now request Professor Sundaresan to take over.
Thank you. Can you hear me now?
Yeah, please go ahead.
Yeah, thank you. So thank you for the invitation to give this colloquium. I'll speak about agent-based simulators for the study of COVID-19 spread. This is joint work with TIFR Mumbai researchers. Okay, so let me begin with some quick acknowledgements. So I would like to thank our development team at IISc. We have a large team here, as well as the TIFR team. We have a large team there as well. And then SAP helped us build some user-friendly user interfaces. And also the user interfaces are mobile-friendly as well. I'll show you some of the tools that we have built. So I'd like to thank SAP as well. And then many colleagues from IISc, NCBS, TIFR, ISI, St. John's Research Institute, Christian Medical College, Vellore, IMSC, Strand Life Sciences, Vadvani AI, and the Data Science Consortium. So finally, I would like to thank Cisco CSR for funding the Center for Network Intelligence, whose staff helped build all the tools that I'm going to present today. Okay, so this figure is how COVID-19 has progressed in India. So we had the national lockdown on the 25th of March. At that time, we had about 562 cases and 9 deaths. And through until 6th of June, 7th of June, we've had this increase. The rate of increase has come down, but it has nevertheless increased. So what you see here in orange is the number infected, the green is the number recovered, and this brown here is the number who have died. The disease is 6929 as of 7th of June. So this is courtesy Shivatria and his team at ISI. So the lockdown's initial goal was to suppress the transmission of COVID-19. And from the beginning, we realized that we needed tools to evaluate unlocking strategies. And so we built tools. And I'll describe the tool, the first tool that we built, which is the agent-based city scale simulator. It's an open source tool available from GitHub. Also, you can look at a toy version at this website, cni.isc.ac.in/simulator. We also built another tool, which is a workplace readiness indicator. This one essentially is sort of a self-assessment tool for firms, companies, organizations, something like Arogya Setu, but for firms and organizations. So for whom did we do this? Our goal was to essentially help city and state administrators from the very beginning. So we have worked with the Karnataka State Disaster Management Authority in Bangalore and the Brihan Mumbai Municipal Corporation at Mumbai. We also wanted to take it to other cities. We have some volunteers, but we have not been able to get much traction with the other cities. So as far as the workplace assessment, self-assessment tool is concerned, that's largely for organizations like MSMEs, IT and IT-enabled companies, and government organizations. Okay, so we have also built, we have also used our tool for various studies. So there's various phase emergencies that we had studied about a month and a half back. I will, in this particular talk, speak about two of them: importance of compliance and impact of train services in Mumbai. And then there are also other studies related to what type of containment zones should one use. Okay, so before we get into these agent-based models, let's first get familiar with pandemics. Is this a one-in-a-century pandemic, the COVID-19? So let's go through history quickly. We had the 1918 Spanish flu, which was also called the Bombay fever. So this was caused by influenza A virus, also known as H1. The specific one is H1N1, and it resulted in 5 crore fatalities. In 1957, we had the Asian flu caused by the influenza A virus, known as H2N2. That resulted in about 10 to 20 lakh fatalities. In 1968, we had the Hong Kong flu caused by influenza A virus, known as H3N2. That caused about 10 to 40 lakh fatalities, mostly elderly individuals. In the 70s and 80s, we had lived with HIV. 7.5 crore were infected and about 3.2 crore fatalities, but mostly due to secondary illnesses. 2002, we had SARS, which originated in China. This virus is what is called SARS-CoV, coronavirus. And this resulted in about 8,000 cases, 774 fatalities. To this date, we don't have any vaccines to protect us against this virus. 2009, we had the swine flu, influenza A, known as H1N1, for which vaccines are available. In 2012, we had another scare, which was the MERS virus, Middle Eastern. This originated in Saudi Arabia. The virus is known as MERS-CoV, once again from the coronavirus family. To date, we don't have vaccines for this. In 2014, we had the Ebola. That virus is called the SEIR EBOV, or Ebola virus. Again, we have no vaccines. And now we have COVID-19 caused by SARS-CoV-2 virus. No vaccines yet. Just how severe is COVID-19? So let's compare the situation with the 2017-2018 influenza, seasonal influenza in the USA. And I'm comparing it with USA because USA has the largest number of fatalities as far as COVID-19 is concerned. So in that season, about 4.8 crore cases were there. A significant fraction, about 2% of them, required hospitalization. And the number of fatalities were 80,000, which translates to about 0.17%. Our estimated numbers, so there are now 20 lakh confirmed cases in the United States, but the estimated number is perhaps closer to 1 crore. So the number that require the number of severe cases that may require hospitalization is estimated to be about 4%. We don't know this for sure, but these are our best cases. And the number of fatalities is 1.11 lakh, which if you take into account the estimated number, comes to about 0.5 to 1% case fatality rate. Now, if you compare it with the SARS-CoV virus, which was there in 2002, the case fatality rate for SARS-CoV is about 10%, and this is between about 0.5% to 1%. So it's more severe than the seasonal influenza, but not as severe as the SARS-CoV that reached in 2002. If you compare it with the 1918 influenza, which was caused by H1N1, The fatalities then were significantly high, 6.75 lakh in the USA alone. That's roughly about 8 times or so. 1.2 crore died in India, and overall about 5 crore died. The case fatality ratio for that was about 10%, but perhaps we might have fared better with the kind of medical facilities that we have now. Okay, so here is a quick rundown on our knowledge of SARS-CoV-2 as on date. So this virus is close to the SARS-CoV-2 of the 2002 outbreak in China. There is overwhelming evidence that it is zoonotic, despite some speculation that it is not. There's only circumstantial evidence that it may show, like other flu viruses, lower virulence during summer. It's quite infectious. The R0 is estimated to be between 2 and 3. So that's the number each individual is likely to infect. And so one would like to keep this to be smaller than 1 so that the branching process that arises naturally dies down. The transmission, I think we all now know, is mostly through respiratory droplets. The virus has been detected in some, for example, printers, keyboards, and doorknobs, which were used by infected individuals in some Chinese studies. And there is also circumstantial evidence from a Singapore investigation that it could be transmitted through contaminated surfaces, and that's called fomite transmission. But I think it's not yet the extent to which this is a significant factor compared to the respiratory droplet transformation is not clear. It mostly enters our body through mouth, nose, or eyes. Is everyone susceptible? This is not clear. It is safe to assume that everybody is susceptible. There is also a large amount of variation in severity among those who carry the virus. There are some that carry the virus, but they're asymptomatic. And there are some that show severe symptoms for the same amount of viral load. The factors for this individuality are not yet understood. It mostly affects the respiratory system. Currently, there is no evidence that mutations which have accumulated since December affect disease characteristics. So we can use the models that we have used thus far to continue to predict how the disease might pan out. Some mutations have been reported. So these mutations do affect the testing that we use for this virus, but these mutations are rare. As for testing, you do a testing for the virus during the infection stage, but then you look for antibodies once you've passed through a certain stage. Maybe after the 7th day or so, you look for one kind of antibodies. And then after about 10 or 12 days for another kind of antibody. You would have heard about happy hypoxia, cytokine storm leading to ARDS, and so on. I'll not speak about them here. They are more clinical in nature. And at present, I'll end by saying that there is no proven medicine for prevention or treatment, but there are many studies which are ongoing for remdesivir, HCQ, as well as convalescent plasma treatments for the effectiveness of these remedies. Okay, so modeling. While we continue to wait for vaccines and medicines, we have actually turned to largely case identification, case management, and other non-pharmaceutical interventions to address the pandemic. Models have guided the use of such non-pharmaceutical interventions, but mostly by scaring the wits out of us. And so today's discussion is going to be I'll begin with the simple SEIR type model. Then I'll move to the agent-based model, which is the main topic for today. And then I'll describe some outcomes of our agent-based model. Okay, so what are SEIR or SEIR or SEII-R models? A quick primer. So consider a closed system of n individuals. Each individual is either susceptible or infected or recovered. S for susceptible, I for infected, R for recovered. And at time t, I'll use S of t, I of t, R of t for the number of susceptible, infected, and recovered individuals. Now there's a conserved quantity, and that's S of t plus I of t plus R of t. That's always equal to the number of individuals because it's a closed system. An initial number of nodes are infected. Let's call that I0 and let's see how the infection pans out. So here is a certain contact model, and the contact model will be familiar to many physicists. It's a homogenized model for contacts, and it recognizes that perhaps individuals meet roughly a constant number of individuals in a day, which is independent of the size of the population. So let's say that it's some number which is order of 1. This is like saying each individual meets a certain number of individuals proportional to the time. So I'll use beta delta t by 2, number of other individuals, in a time delta t, which will essentially give you a meeting rate of beta over 2. So meeting rate with other individuals. So since I'm looking at a one-sided contact, that's why the divided by 2 enters into the picture. But this is sort of a sparse model. So you'll see the picture on top here where we have a sparse model. What we do in order to build the SEIR model is to homogenize this model. And the way we homogenize it is, we say that though we recognize that each individual may meet only a finite number, we'll act as if this individual can meet anybody in the system. But we will maintain the expected number of contacts, or we'll maintain this contact rate. And so what we must do is, we must normalize when we homogenize. We must normalize the meeting rate so that the expected number of meetings in a day is preserved. And once we do this, basically any pair can meet, and these meetings are independent of each other. Another thing to keep in mind is what is called the effective contact rate. So this effective contact rate is the actual contact rate, but not all contacts can lead to infection. And so one would like to take into account the probability of infection, but this is something that is not observable. And therefore, what one actually sees is the actual contact rate multiplied by the probability of infection, which is the effective contact rate. And we'll just take that effective contact rate to be the one that's being modeled by effective meeting rate or contact rate is modeled by beta over 2. So once we have homogenized this, it's basically a network where anybody can meet anybody else. The meeting rates are fixed, and infection spreads through these meetings if a susceptible person meets an infected person. There is one more factor, and that is an infected individual can get cured, and we assume that this curing is spontaneous and it's given by a particular recovery rate. For COVID-19, from clinical studies, this is roughly about 10 days, which translates to a curing rate of about 0.1 per day. Okay, so once one has these individuals, these states and the contacts, one can set up a Markovian dynamics for the rate of increase for the number of susceptible individuals, the number of infected individuals, and the number of recovered individuals. The number of susceptible individuals can only go down, and in a small delta t interval, the expected number by which it goes down, that's given by this, and it goes down, that's why we have the negative sign, is the expected number of contacts which are effectively infection inducing. And for this, an infected individual must meet a susceptible individual. So one can write this down quite easily. If you look at the expected increase in the number of infected individuals, whoever has become infected from the susceptible state, they have moved to this infected state, so we have to count all of them. But in addition, we might lose individuals from this infected state to the recovered state, and that is governed by the recovery rate. And so we have the addition coming from new infections and the recoveries. And the balance is essentially the rate at which the number of infected individuals increase. What we lose to recovery is what is gained by the recovered state. And so that's the mu delta t IT here. So once one sets these things up, you divide by delta t and take delta t down to 0, and you get what is called the generator for a Markov process. So this gives a description for a Markov process. And then one can study this particular Markov process. But in addition, what one does is one lets the number of individuals scale to infinity. So for that, we rescale by n, look at fractions, and then pass to the limit as the population in the system goes to infinity. And we get a limiting ODE system and these random trajectories will essentially track this ODE system. One can prove a theorem about this as well, but what one eventually gets after one does that is this ODE system, which says how the number of susceptible individuals always goes down. It goes down at this rate. How the number of infected individuals may go up or down. It depends on whether the susceptible individuals is smaller than or larger. Go up. So if it is larger than mu over beta, and it goes down if it is smaller than mu over beta. And how the number of recovered individuals goes down. So one can fit these parameters for the India data. So what I have here is the cumulative number of cases, and that you can get by just gathering how many have been infected up to time t and how many have recovered up to time t. That's the cumulative number of cases. You look at this in the log plot, and so if there is exponential growth, you ought to see a straight line. And so that's exactly what we see here from March 5th or so all the way up to April 7th. And then there is a change to possibly another exponential growth, a different constant here, different slope, and that's post-lockdown. So for those interested in some numbers, the contact rate is actually about 1/4 per day during this period, and it's about 0.15 per day. That's this during the post-lockdown period. That translates to an R0 of about 2.5. So every individual roughly infected 2.5 individuals during this phase, and post-lockdown infected about 1.5 individuals. And if you prefer to think in terms of doubling time, the doubling time during this period was about 4.5 days, and post-lockdown it's about 15 days. Okay, so just from the simple model, one can get many insights. It's also, as you can see, a very good fit, except that one needs to change parameters taking into account the lockdown. So one gets, one recognizes or realizes that there is exponential growth in the initial stages, and then it tapers off. There's a sigmoidal growth. But you also see, very interestingly, this notion called herd immunity for those who haven't seen this before. So in order to recognize that, you just have to go and look at this particular equation and see when the system is sort of stationary, that is ds by dt, di by dt, dr by dt are all 0, yet not everybody is infected or recovered. That means S of t, the number who are susceptible, is positive. And that's actually possible when S of t is equal to mu by beta, so then the I doesn't increase. And in fact, if S of t is slightly larger, smaller than mu over beta, and then what happens is I decreases exponentially, whatever be its value, to 0. And therefore, the number susceptible will also go to 0, because the rate at which it decreases goes to 0. The number susceptible will stay constant, because the rate at which it decreases goes to 0. And so herd immunity is attained when S of t is roughly mu over beta. So that's something that you quickly get from the equations there. But the drawback with this, and I'll point out several drawbacks with the simple model, is that the lockdown actually started on the 25th of March. But if you look at this plot, it creates a change in the slope only after about 7th of April or so. Now what's happening here? So that's something that is not explained, because the lockdown began on the 25th of March. Now, to get some understanding of that, we need to understand the disease a little better. We need to understand the disease progression in an individual. So when a person gets exposed to the virus, we believe we do not have immunity to this. So that means this individual is going to fight the virus, and there is an increase in viral load during this incubation period. It is now from various studies, we believe it is about roughly 4.5 days for the incubation period. And then an individual may start leaking the virus. Now this leakage of the virus may be either because he's on the threshold of winning the virus, those are the asymptomatic individuals, or he's on the threshold of succumbing. And those that essentially get over the virus, they may still transmit. There is a possibility of that. That's called asymptomatic transmission that happens here. And then those who succumb to the virus and who start showing symptoms, they may leak prior to actually showing symptoms. That also has been well established in some studies. And so one might have asymptomatic transmission during this period or pre-symptomatic transmission, and then we enter into the symptom stage. Now, what are cases in, when is a particular case recorded in India or in any other place? It is when somebody has actually done a test on that individual, either because this person reported to the hospital, or perhaps there has been some sort of contact tracing that helped the authorities identify that this person is COVID positive. So that takes some time. For example, the symptoms may last for some time, and then the person may go to the hospital seeking care, and only then we might be able to detect that there has been a case. And so the expected time for this is roughly 4.5 plus another half. That's about 5 days plus another 5 days. So that's 10 days. So between 25th of March and 7th of April, that's about 12 days or so. And that possibly explains why there has been a delay. What this essentially means is that we can't just use a simple SIR model. We need to take into account other stages of the infection. And so we need what are called more compartments. We need an exposed state, maybe a sort of pre-symptomatic or asymptomatic infectious stage, and so on. This is exactly what has been done. Yes, Shubhra has a question. Go ahead, Shubhra. You
Hi.
might have to unmute your mic. Yeah.
Yeah. Can you hear me?
Yes, I can.
Yeah. So quick question. So these numbers that you have, like 4.58 days and 2/3 and 1/3, which data do these numbers come from? Is it global data, diamond principles? Are these numbers specific to India?
So many of them are actually based on clinical studies that have been done on the Wuhan cases, as well as some cases in the UK. There has been more data, but the numbers that they seem to be indicating are not too far away from this. So these are based on early studies. The particular paper would be Verity et al. I think I'll come to that a little later.
Okay. All right.
But I must point out that some of these are actually based on models and inferred parameters, because you can't really say this is the expected time. Because you put in a model, you look at a final, some final observed quantities, and then try to find some maximum likelihood estimates for how long this period might have been, and so on. And so these are based on some parametric models which have been fitted.
Okay. All right. Thanks.
Okay. So just to reiterate, just the simple SIR models are insufficient. We need more states, more compartments. And this is one particular compartmental model that has come from, again, a multi-institutional team. This is from Gautam Menon's group, Sitabra Sinha and others. So they have built this model with this many compartments: susceptible, exposed. This is infective, pre-symptomatic, infective, asymptomatic. Then this is symptomatic. This is mild infection, recovered, hospitalized, and then deceased. And you can see here that there is a certain fraction that moved from susceptible to exposed. And that's governed by the beta parameter that we had. But this beta depends on contacts between susceptible and pre-symptomatic individuals, susceptible and asymptomatic individuals. These are the contact rates. Susceptible and symptomatics, and susceptible and mildly infected. Okay, so this is a standard model that has been used. Now, this model is not new, although the parameters have been fitted to the COVID-19 circumstance. So let me rewind back a century to Mumbai 1905, when the population of Mumbai was about 1 million. So here is a study by Kermack and McKendrick, where they actually modeled the spread of, you'll see here, the figures of deaths from plague in the island of Bombay from December 17, 1905 to July 21st, 1906. So this particular curve here that you see is from the SEIR model. They had several infective compartments, and the dots that you see are actual number of cases in this many number of weeks, the number of fatalities in this many number of weeks, not cases, but fatalities. And so you can see that this is something about a century old now. Now, what are the drawbacks of this? The first thing that I said is that with more compartments, you can handle this particular discrepancy, that the lockdown actually shows up only around the 7th of April. But how do we know what the post-lockdown contact rates are? So the post-lockdown contact rates seem to be about 60% lower. So this is 0.25. It has been lowered to about 0.15. Is there some way by which we can corroborate this? And in fact, there is a way by which we can do this in a post hoc fashion by looking at mobility data. So this is actually Google's summary mobility data for the state of Karnataka. So it's based on a very small fraction of users who have Android phones and who have actually given an okay for Google to use their location services. So for those individuals, Google has noticed the following reduction from the normal baseline. The baseline is sometime between January and February. So they looked at what kind of presence individuals had in retail and recreation areas. And there has been a significant decrease since that baseline after the lockdown during the period, in fact, April 4th to May 16th. This is near grocery stores and pharmacy stores. There has been a steady increase of that. Parks, there was an initial high value. There was still a good reduction, but there has been a further decrease, let us say, after about 20th of April or so. This is in transit stations. So, excuse me. So Karnataka still had some minimal transport, mostly for essential services. And this is in those transit stations. Buses, about 300 public transport buses were operational during this period. And this is in workplaces. So as you can see, there has been a slight increase as time progressed. That was because since about 25th of April, some industries had started opening up. But you will see here that this is about 33% reduction. That means that the contacts perhaps have reduced from the usual 100% that's baseline to about 66% of the baseline. And perhaps that could explain the 0.25 to 0.15. This is only a post hoc justification, but that seems to at least match up with the 0.25 to 0.15 reduction. So that's one way by which you could justify the parameters, the contact rates. But when you're actually doing these studies, when you're trying to predict whether to open things up or not, how does one guess? And that's another issue. So how do you get actionable insights from these SEIR models? These SEIR models typically have, so what kind of actionable insights? I would like to describe a few. So these SEIR models are homogeneous interactions across the entire population. I described the homogenization also that one uses to get to the SEIR as via a limiting argument. But we might want to know who are vulnerable so that we can safeguard them. So that's one thing that the SEIR model may not help us with. It could if we include more compartments, but if you're doing that, perhaps there might be other ways of dealing with those situations. At the beginning of the epidemic and also at the end, near the situation when we get herd immunity, the behavior is stochastic. And one would like to understand in such situations, for example, at the beginning, what's the chance that we might end up in a pandemic situation, that is, things start growing exponentially, or what's the chance that this epidemic may die out? This, I think, was the fortunate situation in Bangalore until we started seeing new infections coming from elsewhere. The number that we had in Bangalore was under control, and we knew exactly which pockets they were coming, just isolate them, make situation, whereas in Bangalore, we were in a more stochastic situation. But we would like to understand in the initial stages of the epidemic, what's the chance that this might happen? Similarly, how long might it be before the epidemic actually dies? when it is near the herd immunity situation. So near that point also it's stochastic. So these are things that the SEIR model as it stands may not be able to. One must possibly provide some additional modification to it and analyze the ODE in a finer way, maybe via some boundary layer methods, but perhaps there are other methods, and that's what I want to speak about. Then the other thing is this SEIR, particularly the predictions for India, they were quite good, but is that sufficient? I claim that it is not enough, because it doesn't tell us what interventions to use, or what it doesn't prescribe interventions. So let's go to the main topic of this particular talk, which is agent-based modeling. In agent-based modeling, what we have is a sort of a synthetic city with a synthetic population of agents, and then we model disease dynamics in this. In other words, we basically don't pass to the limit. We look at a large system but treat individuals as individuals, and then we simulate the spread in the synthetic population via the Markov chain, the kind of description that I gave, but before we pass to the n going to infinity limit. So let me explain this agent-based simulator in the context of two city-scale agent-based simulators. So on the left here is Mumbai with 1.23 population, 1.23 crore population. It has about 198 wards, and these wards have varying densities. You will see the population density color-coded here. The darker it is, the higher the population density. We similarly have Mumbai here. Mumbai also has roughly 1.24 crore agents. This is the area under Brihan Mumbai Municipal Corporation. It has about 1.24 crore agents, but it has only 24 wards, unlike the 198 wards here. So the wards in Mumbai are much larger. The average size is about 60,000 individuals. You multiply that by 8. It's about 5.5 to 6 lakhs here in Mumbai. So what one does is one creates a synthetic city respecting the population density as it is given here. So one takes all this data perhaps from census, and then one looks at age distribution, gender distribution, the kind of the number of people that go to work, the number of people that go to schools, and so on. One also looks at geographic information. So what are the ward boundaries? Where is the densest ward located? And so on. And then one instantiates individuals, offices, and schools and other such things, and populates individuals in these places and connects them up. So I'll describe that in a little more detail in the next slide. Once one does that, basically a person is then associated with a household, possibly an office, or possibly a school. Or if the person is unemployed, then the only activity that they might have is non-office and non-school activities, maybe going to the market areas and theaters and things like that. So one creates a network of this sort. And so these are actually various kinds of social networks. So there is a home network, there is a school network, and so on. And then one builds activities on top. Our model is not as nuanced as tracking each individual through the activities that they perform in a day, but it just takes these takes into account these contact spaces in a more abstract way. But one could possibly build activity models also on top of this. So what one has then is a sort of a set of networks, each one sort of finite sparse network, but they're all interconnected. So for example, here these black nodes are individuals. There are 1.24 crores of them, and they are all assigned to households. So those households constitute household networks, and then these would be cliques. And so one models them as a graph. So here are the individuals, and these are the cliques. And this particular model is actually a bipartite graph, where we have one node on the other side for every clique, which is a household, and everyone who's connected to this household interacts with each other. So this is sort of a household interaction space. Similarly, let's take these individuals. They all go to the same school, and so they interact in school. So that results in cliques across the school-going individuals in the population, and that would be another interaction space. So each of these schools is an interaction space. Similarly, you have workplace interaction. So these individuals go to various all these go to the same workplace, and in some sense they connect up these households, and so that would be the workplace interaction and workplace interaction space, and that's also a bipartite graph. Similarly, for markets, maybe a certain fraction of the individuals use public transport, so one has that, and so on. So these are all the various community areas. So as you can see, these are all various social networks. Each one is sparse, but they're all interacting with each other. So let's give an example. So here is a person who might go to workplace and catch an infection there and then bring it back. He might transmit it to somebody, let's say this person who's a young child. That person may go to school and might transmit it to somebody. That individual may go to the marketplace, spread it to somebody, and so on. So this is a means by which infection could spread, and it connects up all these graphs. Okay, so I hope that is clear. So let's go to the next one. How good is this particular synthetic city? So the synthetic city is built based on various census data, as I pointed out. So here is a description of how good, or validation of how good the city is. So on this particular plot, you will see data corresponding to the age distribution, and that's given in the blue, and the red one is actually the synthetic city. This is the household size distribution. How many houses are there? What fraction of the houses have only a single individual? What fraction have two, and so on? And you can see that the blue one is the data, the red one is our instantiation. And in doing this, there is a tricky issue that one needs to deal with. So for example, one must respect this household size distribution as well as this age distribution. But you must also respect some additional constraints, which are age mixes in families. So for example, you will not have a two-person household with an 80-year-old and a 6-month-old. That's highly unlikely. And typically when there are 4 people, there are generational gaps. So one must respect those things also into account in creating this synthetic city. So there are some rules that one has for generating this in a situation where we don't have data, and that's the case in Bangalore and in Mumbai. But in some other cases, there are actually surveys that people have conducted which provides us with this age mix, in which case there's a straightforward sampling strategy for coming up with households that respect the age distribution as well as the household size distribution. The next complication is we must assign individuals who have actually been assigned to houses to either school or workplaces. And when we do this, we must respect the workplace size distribution or the school size distribution. Here is the school size distribution plot. But not only that, we must also respect the assignments following this particular commute distance distribution. So there are some heuristics that we have used to come up with means by which we can match to the data. So the blue is the data, and the red one is what our synthetic city seems to have. And you can see here that we do reasonably well for the small sized workplaces, but for those which are somewhat larger sizes, there's quite a bit of randomness. Here we seem to be doing fine in terms of school sizes. But if you look at workplace distances, the red is our instantiation. So we seem to be making more people travel this sort of 5 to a 20 kilometer distance than what the actual data suggests. So this is a mismatch, and one needs to improve this model to ensure that there is a better match here. Okay, so that's how one generates the city. And that ensures that you have heterogeneity in terms of the connections across various individuals. There's also another heterogeneity within an individual, and this is with respect to the infection progression. We already saw what the progression was. I described this in some detail. But there are some branches here that I skipped when I described it earlier. Those are related to the elderly that pass through these branches at different. There is an age-dependent branching that one has here. Similarly, an age-dependent branching from hospitalized to critical, and from critical to deceased. So I'll describe that. Another thing is comorbidities. I'll describe both of these now. So here is, for example, a study that came up with these estimates. These are, tell me when you lost me.
You were talking about
describing the heterogeneity within an individual.
Yes, you were talking about the specific age group.
Yes.
40.
Okay. So 40 to 49, for example, there's a 4.9% chance that those who are symptomatic in this age group may require hospitalization, and a 6.3 chance that those who are hospitalized may require critical care, and about 50% of those that reach this critical care stage may pass away. So these numbers are some sort of estimated numbers based on data. It's from Wuhan and Italy studies from early March. There have been some newer studies, and we are looking for India data. We don't have the data to modify these numbers to things which are closer to home. Similarly, comorbidities. This is actually more recent data from the 14th of May, but it's also based on data from China, about 1,590 patients. And this tells if somebody is diabetic, for example, what's the chance that a person with a diabetes history may need either an ICU or invasive ventilation, or may succumb to the injury, succumb to this particular disease. And that's 23.8%. So this age stratified numbers is something that we could use in our model. Okay, there are also other kinds of heterogeneities in contacts. Not every individual, for example, infected individual spreads the disease equally. For example, an isolated individual doesn't have a chance of getting the infection, therefore he can't spread it. But those who have small number of contacts may not, or those who work in small workplaces may not spread things that heavily. So that's based on the social network, also the local neighborhood of each of these individuals. There are also heterogeneity factors based on, for example, socio-economic factors associated with the individual. And this might lead to, for example, crowding, and therefore a fast spread in a small locality. There could be severity-induced absenteeism. So, for example, take for example those who have who go to school but have severe infection. The chances are, if their symptoms are severe, then they might take the day off. And if they take the day off, there's a greater chance of them spreading the infection at home than at school because of this absenteeism. And perhaps that could be taken into account. The same applies to workplace as well. There is also a significant amount of variation in infectiousness across individuals. The Public Health Foundation of India doctors seem to suggest that about 20% of the infected individuals have caused about 80% of the spread. Perhaps one could model this, and this one way to model this would be model the infectiousness of an individual as a sort of heavy-tailed random variable. We have not done heavy-tailed, we have just used some sort of a gamma distribution, and that's something that could be brought into the picture. Similarly, infectiousness is higher when you exhibit symptoms than when you're in the pre-symptomatic period. That's because maybe the coughing is less during that period. Also, the viral load may be somewhat lower at that stage, and so on. So that could be something that is a heterogeneity which might be worth modeling. And another one is infectiousness may vary during the symptomatic period. So it might be high during the initial stages and it might die down. This is not the case in our specific model, but that's something that one could bring into the agent-based system quite easily. Why model these at all? So for that, let me go to the next slide. So why model these interaction spaces and these heterogeneities? We want to do this because it enables the study of targeted intervention. So remember that we have various interaction spaces: homes, schools, offices, community spaces, transport spaces. We have also taken into account the sort of demographic aspects of the city or the place that we are trying to model, the unemployment rate there, maybe transportation. Maybe in Mumbai there are about 7.5 million rides a day. That's maybe 3.2 or so 3.75 or so riders. When transportation is stopped, this many riders may use either alternative means or may be discouraged from going to work. That might have an impact on the disease spread. So it enables us to take those things into account. And also we can identify who's vulnerable, who's causing the spread and things like that if we model these things. So once again, it enables study of targeted interventions such as case isolation, home quarantine, social distancing of the elderly, schools and colleges closure, and so on. And similarly, when we open up, it enables us to understand what might be the impact of opening up some industries, what might be the impact of transport services, what might be the, which containment strategy might be the best containment strategy, and so on. Okay, so maybe I have another 5 to 10 minutes. I want to maybe quickly compare some simulators, agent-based simulators, and then move to one or two studies, and I'll try to do this quickly. So as for interventions, because we have these detailed interaction spaces, you can come up with an identification of who are all the symptomatic cases, who all show symptoms. Now, perhaps a day after they show symptoms, we can say that those individuals isolate themselves, which means their non-household contacts could come down, and so on. Also, we could model compliance. To what extent do these individuals respect the case isolation directive from the government? Okay, so that's something that we could do. Similarly, home quarantining, schools and colleges closures, social distancing of the elderly. I'll not go into more details of this. Okay, and then there is another thing that this particular agent-based model enables us to just some of the terminal status. Okay, there is one more thing that one needs to do, and this might attract quite a few questions. So I want to particularly maybe spend a couple of minutes on this. That's calibration. So the way we calibrate it and the way others also calibrate is based on some data parameters. So for example, in our simulators, we seeded about 100 nodes with infections in our city scale simulator. We also calibrated the contact rates and a certain start date when we seeded these 100 infections, so that at the end of the epidemic, when you look at you would have tracked each of the individuals where they got this infection from and so on. We have a good estimate of where they got it from. So in this particular case, we have used an equal infection rate from home, workplace, and schools, because prior studies in other influenza cohort studies seem to indicate that this is about one third. Also, we try to match to the initial death rate during the initial phase. So this was between roughly 15th March and about 9th of April. During that period, there were about 200 deaths. We tried to capture that many number of the slope corresponding to that many number of deaths. So we tried to match this time series. And then as validation, we programmed these lockdowns and saw whether we are able to predict the reduction in the exponent. And this is actually what we see for the India data. You can see that the validation has passed because there is a certain inflection here. Okay, so let's go to some debates about these calibrations. There is this particular saying that agent-based models can be calibrated to say anything. So in defense of these models, what I have to say is that they have been constructed bottom-up. For example, the city census data, household data, etc., are all things that are given to us. These are not things that we play with. We take it as given, and then we build the city according to match these parameters. Similarly, the disease parameters are taken as given as far as the model is concerned. They are based on clinical studies, independent clinical studies, but once those studies have been completed, we take those parameters and then program the simulator with these parameters. And I also mentioned about past flu cohort studies. They sort of suggest relationships between school and office contact rates, as well as what the final infection rate is from home, from school, and from workplaces and community. And so one could use those things here to help us with the calibration. So really the only things that are being calibrated are the home contact rates, the office contact rates, the community contact rates, how many to seed that we had fixed at 100, and then the seeding date, so that the exponent and the timing of the exponential growth matches. So here of agent-based models, agent-based models 4 or so, perhaps earlier, but this study was done in 2008 based on agent-based models from 3 teams: the Imperial College model, the University of Washington model, which the United States seem to be using. Although I think the University of Washington has provided with several models, agent-based model is only one of them. And then there is the Virginia Bioinformatics Institute model. So as you can see here, this is in a particular flu model in the United States. And this is how the 3 models fare. They're roughly between 42 and 46% attack rate in the population when there are no interventions. And when interventions are provided, there are some modeling differences, as you can see from here. For example, here the University of Washington model predicts only a 5% attack rate, whereas these 2 predict an 11% attack rate for certain non-pharmaceutical interventions. On the other hand, if you include, for example, case treatment, identify cases and treat them, then these 2 seem to be in agreement, and they are different from the Imperial College model, and so on. But what this kind of comparison suggests is it draws sharp contrasts between the assumptions and the conclusions, and one can try to then understand and therefore gather a better understanding of what the differences are and why they are turning out to be different. Okay, so that's a quick comparative study. As far as COVID-19 itself is concerned, so here is what the Imperial College model predicted in the no intervention scenario for UK, which has a population of 6.78 crores. It predicted about 5 lakh deaths. And then they proposed a certain pulsated intervention, which would have led to a middle value of about 24,000 fatalities. The actual observed number of fatalities is about 40,000 now. And this has lockdown as an intervention, which is different from what was proposed here. For the USA, they had predicted about 22 lakh deaths. US has about 1 lakh deaths as of now. If you look at, there are these other models. I don't have the numbers for them. Oxford University has put out a model in trying to replicate the Imperial College model. Uppsala has put out a model trying to replicate the Imperial College model. Ours is also an attempt to cross-verify the Imperial College model. So if you look at the Uppsala model, it's Sweden. It's a model for Sweden, 1 crore population. That's roughly like Bangalore. But they predict 96,000 deaths. So this is about 1/6, and that's about 1/5 roughly. And so it kind of matches with the Imperial College model. The actual deaths is about 10,700. They had proposed some interventions, mandated social distancing. Under the circumstance, they anticipate about 25,000 deaths. So our models were for Mumbai and Bengaluru alone. And in the no lockdown scenario, our numbers were similar to that of what we are seeing in New York. New York, it's about over about 15,000 deaths now. It was similar to that. But with lockdown, we predicted these numbers. The actual observed numbers as of 7th of June is 1,500 in Mumbai. We assumed about 90% compliance, and show you maybe 1 or 2 numbers which say that this 90% compliance is perhaps optimistic. Okay, so maybe I'll skip this mini simulator. We built this education tool. I invite you all to go to this particular site and play with it. You can set parameters and you can see how things evolve. You can even set your own interventions here. There are some canned interventions, but our full-scale this is only for a 1 lakh simulator. The population is 1 lakh. Our full-scale simulator deals with 1.25 crore Bangalore and Mumbai. Okay, so I'm running a little out of time. I'll maybe quickly go to just a couple of studies that we have done. We have used our agent-based simulator to highlight the importance of compliance. So maybe I'll not have time for this. I'll move to the second study, perhaps. So let's go to the second study. So the second study is about Mumbai trains and phased emergence. And these are done in collaboration with our TIFR Mumbai partners. So just a quick description of what we studied. We wanted to understand what might happen or how the disease might pan out when we open up certain industries. For example, during the lockdown, we assumed that the compliance is a little lower than what we had earlier assumed. So we assumed 60% in some areas and 40% in some high density areas, because in Mumbai, that's the anticipated from the mobility data. We seem to be seeing this sort of compliance. And then additionally, we have after the lockdown from 18th of May onwards, we have essentially relaxed some of these lockdown restrictions. So for example, offices could operate from 18th of May at 5% capacity. How we have modeled this in our system is that about 5% of the individuals go to work, in addition to possibly 25% of the individuals going to work for essential services. From 1st June to 30th June, offices operate at 20% capacity. And from July onwards, they operate at 33% capacity. Now, trains could be off, in which case people have to use buses, or alternatively, trains could be on at suitable capacities. There are associated numbers for this, which describe the capacity with which the trains are operating. So we study this opening scenario with another somewhat more aggressive opening scenario where the office is open at 33% capacity. We also study the situation when trains could be off and see what might the impact be. We model that face masks are on, because that's what seems to be the case in Mumbai since about 9th of April. And there is also a containment zone model. So if a particular zone has more than, let's say, 0.1% of the cases hospitalized, then only that particular ward is contained. It's completely open if there are no, there's no restriction if there are no cases. And in between these two extremes of 0.1% and 0%, there is a smooth way in which it is contained. So it's sort of a soft containment strategy. What one gets is then this particular plot here. So there are four possible, four curves here corresponding to the four scenarios. The red ones are for trains off, and the blue ones are for trains on. The lower one is for the less aggressive opening, and the higher one is for the more aggressive opening in each color. So you can see that our predictions are something like this. And as validation, we have plotted the actual number of cases. So our simulator seems to be doing well, which kind of suggests that perhaps there is something to these predictions. But this is how things might pan out during these 4 stages. There are some uncertainty windows also that we have provided here. Okay, let me end with a quick summary. So we looked at agent-based models for COVID-19. Why agent-based models? They can handle, they model heterogeneity at the individual level, so that we can try to understand whom to protect or guard. They can model behavioral adaptations. They can model heterogeneity in interactions. The social networks that each of us are in is different, and perhaps that heterogeneity may play a factor, and one could model that here. There is stochasticity in the beginning and at the end of the epidemic, And for understanding those, we might need this agent-based model. There are also interventions. If you bring in these interaction spaces, then we can control them as well. And so we can study targeted interventions. So it's useful for that. Study strategies for testing contacts. So this is something that we are building into our current framework. So that we can model contact tracing as well. It's not yet there, but hopefully it will be there soon. So we highlighted some of our studies. I didn't go into compliance studies, but I did very briefly discuss what might be the impact of opening up trains and what might be the impact of the soft containment zone. Agent-based models can be used in other scenarios also, for example, for traffic studies, and maybe for the effectiveness study of the now on, now off odd even strategy that seems to come and go in New Delhi. Thank you very much.
Okay, Rajesh, thank you so much for that wonderful, informative talk. I will invite any audience members to ask questions. Please raise your hand and I will call out individuals. So I see a raised hand from Subroto. Please unmute your mic and ask your question, please.
Hi, Rajesh, very nice talk. I had a question about the parameters that go into your ABM, into your ABMs, into your agent-based models. You said some of these actually come from real data, and then there are others that you calibrate, right? So I have two questions. First of all, the numbers that come from real data, what are the error bars on those numbers? I mean, when you do you have any idea of what the confidence intervals are on those values, and how much they affect your results? And the other thing is, as far as the parameters that you calibrate are concerned, again, how accurately are you calibrating them? Because you have a lot of parameters. This is some sort of non-linear model, so there could be many different sets of parameters which might give you a similar reasonable fit to the data. So is that something, meaning many sort of local minima or something in parameter space? Is that something which happens at all, and how do you deal with it?
Okay. So first, let me come to the error bars for the fixed parameters, which is city census data and so on. Many of these are actually based on door-to-door surveys, but they are not completely accurate. There are possible errors there, but we don't have actual error bars for the population distribution. So we just have an indication from the census data that this is the number of individuals between 0 and 9 and so on. So for that, we don't have error bars. But for example, office commute distance distribution, there we know that it is based on surveys of about 1 lakh individuals and things like that. So it's not that the entire population has been surveyed and we have this data, but it's only from a small fraction of the population. There we do have some error bars. Now, have we used our error bars here? So the way we have been dealing with this is we have not used the error bars on our city scale static parameters, but like for example, the census data and so on. So that we have not used the error bars. Perhaps we should do, but we have a model for sensitivity analysis of any parameter that goes into our model. So how does one change this parameter and what is the consequence? Now, of course, we have played with that particular parameter sensitivity only for these contact rates. We have not done a systematic study of things here. So that's a thing that we have to do. It's in our study, and we hope to get to it eventually. As far as this disease parameters are concerned, there is a significant amount of uncertainty there. Then the disease progression that I have described is only the best understanding that we have. There are some that use 5.5 here, there are some that use 3 and so on. So there's quite a bit of uncertainty here. There's actually a significant amount of uncertainty in the asymptomatic fraction. So there are studies coming out of Wuhan returnees, Japanese that went to Wuhan and came back. This 33% is based on that. But if you look at the Diamond Princess, the asymptomatic fraction in the Diamond Princess is about 59%. That's had some more elderly population. So that suggests that maybe it might be closer to 66% or something like that. But there are studies in Italy, in a city called Vo, where it's about 44%. So it seems to be varying quite a bit, because these are indirect parameters that you're trying to estimate from some other observations. And so this variability is something that we'll have to live with. And the way we live with is by simulating for various asymptomatic fractions and so on. So that's a long answer to your short question. The way we address uncertainty is by plotting across different parameters. Sensitivity analysis is still in progress, and sensitivity analysis that we do is currently for the contact rates. We will eventually get to the others.
Okay, thanks.
Rama, please ask your question.
Hi. So towards the end of your talk, I saw that your predictions for Bombay, they're a bit worrisome. Like even till 1st September, there's a lot of fatalities even under any of the scenarios. And so I wanted to check what you, like whether you have something similar for Bangalore.
Okay. So in Bangalore's case, we have not been able to get a good model Bangalore has, as of now, I checked yesterday, about 15 fatalities. So let me go back to this picture. So 15 fatalities. We see new cases coming now, but all the new cases are due to people coming from outside, or at least a large fraction of them are due to people coming from outside. We have in our system, we have not yet modeled it. We are still looking at a closed system. So we now need to see new infections and see what the outcome is. So we don't have the numbers for Bangalore. In the case of Mumbai, I think this is still okay, because the new ones, if people are coming back to Mumbai, largely it is only an exodus. But if people are indeed coming back to Mumbai, then that's probably a smaller number compared to what we are already seeing in Mumbai. So I don't have the specific numbers for Bangalore as of today, because of the current situation where most of the cases are because of people coming from elsewhere.
Okay, thanks.
Can I answer Shubroto's question? Because there is another thing that I would like to bring up, which is age stratified interaction. So for example, in our school space, we have modeled only a uniform interaction of all the individuals in the school. But really there is age stratified interaction. There is more interaction amongst individuals in a class than contacts across, let's say, 5th standard student and a 10th standard student. Such contact could be there because there are some common spaces, the wash basins, the toilets, and so on. But it's lower than contacts within a particular age group. And so what one must do, all these calibrations have been done for the situation where we have not brought in this age stratified interaction. But we have that capability in our simulator. And right now there is a study that tries to bring in this age stratification based calibration. And then once you do this, that age stratification is once again, age stratified interaction is once again based on studies that people have done. And then once one does this, one could see, does age stratification, which we know, age stratified interaction, which we know is present, does it impact the estimates? This is something that we are currently studying.
I actually have a question whilst we wait for if anyone else does. Can you talk a little bit more about how you go about validating these models? The graph on the screen is one validation.
Yes.
What are the other metrics that we can actually validate these things?
Okay, so there are some things by which you can validate. Okay, so let me go back to. So for example, this bend in the curve is a sort of validation because that wasn't programmed, or that wasn't, we didn't tune to it. We only tuned to this initial growth rate during the exponential growth phase prior to lockdown. And I say prior to lockdown because the period from exposure to death, the expected time is about, expected duration is about 20 plus days. Lockdown came on the 25th or so, and this is until about 9th. And so the cases that we are seeing, the fatalities that we are seeing here were perhaps prior to the lockdown. And once a person has been exposed, that person is executing a trajectory that's independent of all others, at least in our model. So, of course, he infects others, but his progression is independent of the others. So, this bend is something that we did not program, but this bend, but somehow that is captured. Of course, that's one validation. I'll go to a simulator and I'll point out one more thing that could be used to validate. So you see this curve here which says source of infection. The source of infection is something that we have from studies in flu, when we track flu patients in previous years. So for example, here it is 1/3, 1/3, 1/3. But that's something like this. So this we have used to calibrate, but perhaps there is something like this, which is a study that people may have conducted, and that could be used to calibrate. Now, there's one more thing that one could use. We haven't used the number of cases at all. That's another parameter that one could use to validate. For example, you just calibrate to deaths, but then look at contact tracing, because the rules for testing and contact tracing have been provided. So one could program that and then check whether the number of cases in our model, which has been calibrated only to the deaths, the number of cases matches with the actual observed cases. That's another way of validating. Right now, we have not taken the cases at all into consideration because it's based on contact tracing, it's based on some rules that are there for testing, and only if the test comes out positive do you have a case. So it's difficult to match to that. Whereas deaths due to COVID are, we think, more reliable. So, but once you build in this contact tracing into the model, that's another hook that you could use to validate. So I think these are some means by which one could validate.
I see Srikar has his hand up. Go ahead.
Srikar, go ahead.
Hi, Rajesh. Very good talk. Just a few questions. So let's begin the reverse direction. But just now you mentioned that the fatality data is the most reliable data in some sense.
Yes.
I mean, initially I remember there was a lot of talk about the fatality data itself being not very reliable because people don't know how to associate fatality to this infection. So some people in some countries, the fatalities were reported in a different way. In certain countries, the fatalities were being reported in a different way. And just a point in case that China reported I think some number of fatalities after everything was basically cooled down. So in such a scenario, if suddenly, let's say like after a week, we realize that our fatalities were actually misreported and we want to now update the data, the observations. So in that case, how would the model get updated? Because the learning part is from March 15th to May 1st, right? That's the learning
That is
part.
correct. Yes.
So in that period, if we find out, so right now they suddenly say that they learned new deaths, and these new deaths are going to get added for today's date.
From today's date onwards, but during those periods, it is still that. Yes.
Yeah.
So good point. So I will actually articulate the issue somewhat more specifically. As I think, okay, maybe I'll answer your specific question. When this is the situation, we'll have to somehow go into our model and then modify the reporting strategy for deaths as well, and not take every COVID-19 death, but only those that conform to the or that follow the reporting rules for a particular death. So I'll give you an example. I think West Bengal had said that if somebody reports to the hospital let's say that person has died, and you're looking at the symptoms prior to death. Now, if it so happens that the individual may have suffered the symptoms corresponding to COVID, but if there is a history, comorbidity history, then this person's samples will not be taken, and it will not be written as a COVID positive death. Okay, that's number one. There's another one. For example, if somebody is COVID positive, but let us say that there is this comorbidity, then it will not be taken as a COVID-19 death. It will be taken as something related to that particular prior ailment. So there are these issues, and maybe a rule might come in that you have to include them as COVID-19. If this happens, then there isn't much we can do. We'll have to, our hope is that the rule stays the same across time. But if it changes, then what we have to do is we can't just hope to recalibrate, because when we recalibrate, we'll get the same numbers, because we are recalibrating on the data which was according to the prior reporting rule. So we'll have to bring in these new aspects into our simulator and then work with it. Apart from that, I don't see a fix.
So then, no, my question specifically was second part of the question was basically, if fatalities are some things that we are not very sure about, then why don't we model based on the things which we are sure about, that is the reported number of cases?
So the reported number of cases is based on somebody reporting to the hospital. Correct. And once that person reports to the hospital, you go and do contact tracing. And you take into account rules for who should be tested, right? Correct. So, for example, if it is a close contact, but maybe the close contact is not showing symptoms, at some point of time they were not tested. Now I think they are tested. Yeah. All of these are dependent on what the capacity for testing is, and this capacity for testing has also changed with time.
Correct.
So if you want to track this, you have to essentially program all of these things into our simulator.
Yeah, exactly. So your program already has so many variables. Just introduce one more variable, that is a sampling parameter, that how many people are being sampled. And then, of course, the samples are based on weights, because if not everybody is getting sampled, it's not a uniform sample from all over the country. It's basically very weighted sample. So some people who are showing symptoms, they are the ones who are getting tested. So one can,
yes,
just
this contact tracing based testing is something that we have programmed already. I have not presented the results because we are still trying to see, because there are more parameters. So we need to come up with a strategy to calibrate this. But as I said to I think Vishal's question, that we are not, we could tune to this and use deaths as validation, or alternatively we could tune to calibrate to deaths and then use this as validation. So we were thinking of the latter strategy, calibrating to deaths and then using this as validation. So we have brought in that feature, but it has taken some time because it's a somewhat more complex feature than the others. So, yeah. But yes, good point. And this could be, one could switch the calibration and the validation with cases and validation with deaths. That's
right.
possible.
Just one last comment, which is related to Shubhrito's question also. So he had also asked, like, you have many parameters and the likelihood is going to be very complicated to write down also. So in that case, like estimation becomes quite difficult. So for example, R0, the R0, is it estimated or is it like the observed, like used from other studies?
So we don't actually look at the R0 explicitly. R0 comes as a derived quantity in our simulator. We only look at this growth rate. So if you can see my slides, we only look at this growth rate. Then R0, we track each individual and see how many he has infected in our simulator. and that then is reported as an R0. Of course, this is going to change with time as well. So when we compute the R0, we have to compute it for individuals infected within a week. We also have to see until they recover. So that might be a 4-week period from the point where they got infected. So we'll have to track how many people they've infected during this period. And this is for all those that got infected in a 1-week period. That's our R0 for that week. And then for the next week, maybe the epidemic has evolved in some way. Maybe there are fewer susceptible individuals, then the R0 may be a little lower. So that estimation is something that we can do, and we are. I'm a little ashamed to say that we have not yet put out these plots of R0s, but we only looked at doubling times and things like that. Those plots we have, but what exactly is the R0, we have not done. Lastly, because we think it's a good epidemiological parameter to give epidemiologists an understanding as to what the state of the epidemic is. But to us that are coming from the computation perspective, everything is indicated by the doubling rate. And so we focused on the doubling rate. But you're right, we should get the R0, and we've just put in the code for this, or at least it'll be in our next study perhaps.
Thanks.
So someone has sent me a question directly because their mic isn't working. I'll read it out.
Okay, please.
Adip asks, is there an upper estimate on the number of infected people presently? There was some study in Italy which made a study on how many people have reported some symptoms. Is there something similar in the Indian context?
In the Indian context, I don't know about the Indian context, because only now, I think in about 9 districts or so, the tests for antibodies have been ordered. I think we are going to see the results sometime soon. So that might give us some estimates of how many have actually been infected. But I think similar studies were done in New York. I can say about them, about 150,000, 1.5 lakh people were tested. So let me just go to that particular place. So here. So for example, where did I get this roughly 1 crore from? Actually, this is based on 2 kinds of estimates. Both of them point to about 1 crore. This is in the United States, where there are 20 lakh confirmed cases, and about the estimated number of cases is about 1 crore. So if you look at New York City, for example, New York City has about a little less than 20,000 fatalities, between 15 and 16,000 fatalities, and a large number of cases. But when you looked at the, so it's 1.7 million divided by 5. That's the number of cases. They looked at the tests and found about 20% of the individuals amongst these 150,000 to be positive. Okay, many were, they didn't even know they had the infection and so on. So that's 20%. If that is 20%, New York's population is about 8.4 million. That comes to about 1.7 million people infected in New York. And New York is in a fairly advanced state of the infection right now. So I would guess that that's a good indication from the tests that they have conducted. So I think the tests will be conducted in India in about 9 districts perhaps to begin. And so though the outcome of those tests will tell us what the prevalence of the disease is.
Okay, so there's one more hand up. Please ask your question.
Hello, I have a very basic question. You mentioned that the population of Mumbai you have taken is about 1 crore or so, 1.2 crores.
1.25 crore, yeah.
Okay, so if I go by the regular, death rate of in a society, typically it's about 1.2% or 1.5%, somewhere in that region. So if you calculate it, it's about 400 deaths per day, 400. Okay. Now, in your graph, it shows about, for the Mumbai case, that you go all the way up till 70 per day. Now this 400 per day normal death rate is about almost a factor of 5, 6, 7 times more than this 70 per what you're mentioning. So I'm just curious, what is this
70.
let's say 70, yeah, because the 70 seems a small fraction for about compared to the regular death rate. So is it the fact that there is the medical infrastructure is just unable to cope up with even this extra 70? Is that the real issue, or what exactly is happening? Or is it concentrated in some pockets? Or
this 70 is
exactly what.
This 70 is exactly, or these numbers that you see here are those who have been tested COVID positive. So these are cases as a consequence of COVID. And there may be, I think your estimate of about 400 or so is the normal case. And so there is an interesting study that one could do here. So for example, one could look at how many last year and how many this year, and then study the number of excess deaths. So definitely the number of excess deaths will be perhaps not all these 70, because some of these may actually be people that may have succumbed to some other diseases during this year. So, but one could still see whether there has been an excess over last year.
Yeah, I think I have seen some of these kind of studies. And for example, New York, I noticed that the regular death rate and the COVID rate, they're almost equal. Okay, and that's one of the things which I was curious was in your model. Have you modeled the capacity of the infrastructure to handle these infections and other kinds of things? I go, death also is a terminal state, but the infections itself, where is the stuff in the model?
Where is the last question? So what was the last part of the question?
Infrastructural rigidities with respect to handling infections, handling deaths and all these things.
Okay, so with respect to handling infrastructural requirements, like for example, what might be the number of people who might need hospitalization, critical care and so on. Once a person has been infected and he has passed to the symptomatic stage, and let's say he enters the hospital, from then on there is a progression that this individual follows, and we have a model for that. Now, that model gives us what might be the capacity requirements, etc., under the assumption that there is no capacity hitting, right? If you want this many number of beds, you get that many number of beds. Now, the point you're bringing up is a very interesting point, which says that we have, let us say, in Mumbai, only about 6,000 beds. And the estimated number of beds that might be needed are 7,000 or 8,000. That means some sort of triage is going to happen, and people are going to be asked to take some sort of care in a clinic or at home. Now, this is basically a pushback because there is a capacity limitation. And because of this, they might not get the necessary care, and this might cause an increase in fatalities. So this movement or this restriction as a consequence of capacity limitations, we ought to model, and we have not done that. And this modeling will require an understanding of exactly what the critical care facilities are, and also what the policy is. That we don't know. This policy is also changing with time. So it's a little more complicated to model than what we have. But nevertheless, it's something that would be worth modeling in a situation where things may go out of hand. For example, this happened in Italy. And so we might...
I think in Delhi, it seems to be already the case, because the chief minister there has already said that no non-locals.
Outside Delhi, only for locals. Yes, correct.
Yeah. Okay,
right now, I think we hadn't hit the capacity. So in fact, we use the capacity to isolate patients, even though perhaps they really didn't need hospital care. But in Delhi, as you're pointing out, I recollect this particular item, news item that came this morning.
Thanks.
Yeah, thank you. Thank you for the question.
Okay, I don't see any more questions. So I think I'll take the opportunity to thank Professor Rajesh Sundaresan again for his wonderful talk. With that, we conclude the first online ICTS colloquium. Please feel free to unmute your microphone and give Rajesh a round of thanks.
Thank you very much.